Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Rouleau University Medical Center. I'm Ronak.
No Vivek, and I'm Dan.
And in today's episode, we continue on our testicular cancer journey. This time, we have a very special guest on our show. This is Dr. Amar Kishan, who's a radiation oncologist at UCLA. And this is one of our super important, super high yield, and really well-received multidisciplinary discussions. And so, as our listeners know by now, radiation and surgery play a big role, or potentially may play a big role in the management of our patients. And so it's always nice to hear from our colleagues.
Yeah, just like you'd want opinions from all these specialties at Tumor Board, it's really important to try and understand where folks in other fields are coming from and the things that they're actually doing when you refer a patient out to them. So really great discussion today. I mean, the standard model of particle physics gets a shout out, so you know it's going to be a good time. Definitely stay tuned for this.
And Vivek is unfortunately taking care of some clinical things, so he is not joining us this evening, but Dan always loves when he gets to do Vivek's intro, so he's got a smile on his face. So guys, without further ado, let's go ahead and roll that show. Guys, we're so excited to kick off our radiation oncology discussion on testicular cancer. And this time we have a special guest with us. We have Dr. Amar Kishan, who is a professor and executive vice chair in the Department of Radiation Oncology at the David Geffen School of Medicine at UCLA and the UCLA Johnson Comprehensive Cancer Center. Amar, thank you so much for being here this evening.
Thank you so much for the invitation.
We're super excited to learn from you, as of course you know, and as we learned in preparation for all of this, the literature about the role of radiation oncology in testicular cancer is interesting. And so we're certainly excited to hear your thoughts about all of this. We always like to kick off our show with our guests telling us at least one fact about themselves. So I'll turn it over to you.
Sure. So one interesting fact about myself is I'm actually a huge fan of professional wrestling, to the extent that for my recent birthday, my gift was ringside tickets to the Netflix debut of WWE Raw, which was right here in Dome in Inglewood, which is like 20 minutes from Los Angeles.
That sounds amazing.
Can't saw the Rock in person. So,
oh my gosh,
Maui himself.
That's next level.
Is he as gigantic as he looks like he is on TV?
Yes.
Incredible. This has to be a fellow on call first. I don't think anyone has ever said that they were huge fans of wrestling. So you win the trophy there.
Certainly one of our most fun facts. But to dig right into it, as a radiation oncologist, what kind of guidance do you have for us with regard to particular imaging or other studies you feel patients should have done prior to their appointment with you to help expedite their treatment course? Basically, what information can we ensure we get over to your office as soon as possible to kind of smooth things over?
Yes, great question. I mean, I think for us, it's going to be CT imaging, which ideally was obtained during the initial workup, which is key to staging testicular cancer. And I think we're going to be focusing mainly on seminoma. So it's integral to the staging of seminoma. And also, it's always helpful to have tumor markers checked, like beta HCG, LDH, AFP. And then finally, if there's been some discussion about fertility, that's always helpful. And we may circle back to that at some point. But that's always a big thing in this largely young population of patients.
Okay, so that initial imaging is important. That's good to know. Yeah, instead of just like the post chemo or whatever. Okay, excellent.
That's really, really helpful. We love asking that question because, as you know, most of our listeners are medical oncologists. And so it's good for us to know sort of what we need to send over to you just to keep the ball rolling. One of the things that we've really highlighted for our listeners in our series is that really the importance of confirming seminoma versus non-seminoma and the importance of staging. And so to remind our listeners, radiation is an option for patients with stage 1 seminomas or stage 2 seminomas that are less than 2 centimeters. So focusing first on that stage 1 seminoma, Amar, how has the role of radiation therapy in managing early stage seminomas evolved with the advent of alternative treatments such as active surveillance and chemotherapy? And really, if opting for radiation, what does that treatment course really look like?
Sure. So, I mean, historically, radiation has been used to treat seminomas back to the 1920s, even. Seminomas are explicitly radiosensitive. But given the fact that this, again, is a disease largely of a younger demographic, there are concerns about long term morbidity. So, there's been a big push within our field, as well as in the oncology field in general, of trying to reduce the intensity of radiation. That's either dose reduction or field size reduction. And that's really, led to even the omission of radiation, which is, active surveillance, which you mentioned. And so this has been studied in various sequential trials that looked at going from traditional, what we call dogleg radiation, which is treating the periordics and also the ipsilateral pelvis, down to dose reducing that and then eventually just treating the periordic fields only. So in a modern day, if someone's opting for radiation in 2025, the treatment is just TA field. So it's a periordic field. The superior border is like the T11, T12 interspace. The inferior border is the L5S1 interspace. And it's 20 gray and 10 fractions, meaning the patient will come 10 times to the treatment facility. Typically, that's like Monday through Friday, 1 week, and then Monday through Friday again the next. It's a pretty straightforward treatment. The one exception would be if the patient has a history of prior pelvic surgery, typically like a hernia repair or an orthopexy. Then we do think there could be some altered lymphatic drainage, and we do go ahead and treat that older dogleg field, which includes the ipsilateral pelvic nodes as well. And in that case, would be treating kind of to the superior border of the acetabulum. In terms of how that's tolerated, it is pretty well tolerated. The main thing I consult patients about is nausea and vomiting, just because of the superior extent of that field. There's some dose that can affect the stomach. And so I actually just give my patients a 4 milligram daily dose of Zofran to take like 30 minutes before each treatment. And that usually gets them through it pretty well. There's also a little bit of fatigue, which is short-lived, tends to resolve within 1 to 2 weeks after treatment is completed. Diarrhea can occur too, and I tell patients, you can take Imodium, and over-the-counter diarrhea is fine. This is an inflammatory process. You mentioned surveillance, and so surveillance is the preferred option for the vast majority of stage 1 seminoma patients. So that's based off of a number of well-done studies that show that without adjuvant treatment, the risk of recurrence is only 12 to 20%, which is very low. Most relapses, if they occur, are in like a stage 2 distribution. So it becomes similar to if someone had presented with stage 2 seminoma, which is obviously curable. And so survival is extremely high, even if someone is doing surveillance as the first step. The major kind of change and development in surveillance, which hasn't really percolated into our practice here, is the European study T24 trial that looked at maybe MRI-based surveillance as opposed to CT-based surveillance for these patients in a reduced intensity surveillance, where it's actually just getting scans 3 times over 36 months as opposed to 7 times over 5 years. And in that study, which was like this 2x2 randomized trial where patients were randomized to either getting MRI or CT and then 3 versus 7 surveillance scans, there was a non-inferiority for the reduced intensity surveillance and for MRI. So it's a pathway for patients to get out of any radiation exposure if you're getting just an MRI a couple of times. One of the barriers to that, though, is insurance approval. And sometimes those scans can be harder to schedule than just a CT scan, less comfortable for patients. So it hasn't really percolated into practice, at least in my neck of the woods. But it is published in the literature as a randomized. The only other thing I would note is there have been some nomograms and risk stratification schemes that have been published over the years, basically trying to answer the question, are there patients in whom maybe there is a high enough risk of recurrence that we shouldn't do surveillance, that we should treat them? Historically, out of Canada, Princess Margaret Hospital, there was a 2-step system where basically the presence of greedy testis invasion on the pathology or a tumor larger than 4 centimeters, which it's a high enough risk that maybe you consider just doing adjuvant radiation. There was a recent individual patient data analysis that was published this past European Urology that looked at over 1,000 patients, and they try to refine that. They found that because in the modern era, that smaller tumors in general and greedy testis invasion is kind of, they tried to make it more rigorous. That's defined. They found that they made a risk stratification scheme of low, intermediate, and high risk based on tumor size, less than 2 centimeters, 2 to 5 centimeters, or more than 5 centimeters, ready testis invasion, and lymphovascular space invasion. Basically, the risk of recurrence was less than 20% for the low and intermediate risk. It was really just the high risk that had all bad features that had like a 40% chance of recurrence. Maybe that's a group in which you think about doing adjuvant treatment, but you could also just probably closely follow those patients as
Okay, that makes a lot of sense. I'm glad that you mentioned the orchidopexy as a potential thing that might alter your radiation field. That's really important given that cryptorchidism is a big GCT risk factor. And, always cool to hear that we're trying to back off on how much therapy we're recommending to folks just to see if we can't spare some toxicity. Moving towards stage 2. So in cases of stage 2 seminoma, we'd previously discussed a 2015 meta-analysis published in Annals of Oncology, which included 13 studies comparing chemotherapy to radiotherapy, in which they found improved relapse rates for patients with nodes greater than 2 centimeters with chemotherapy over radiation. But in stage 2A disease, how do you think about the role of radiation there?
Then that's a very important meta-analysis. We're very familiar with it in the radiation oncology world. We're probably a little bit biased, and we pick apart what could be the limitations of that analysis. So I'll use this platform to dispense it. Two limitations are follow-up was longer in the radiation series, so there's a longer window in which the recurrence could occur. And this was before the era of CT staging in a lot of the radiation series, at least. As I mentioned in the beginning, it's important to have CT staging. It used to be, we just have like a chest X-ray being clear, and these patients didn't have CT abdomen pelvis. So you could be missing kind of more significant nodal disease at presentation. All that said, you're absolutely right. I think the NCCN guidelines basically state that for stage 2A seminoma, radiation is a great option. And then for stage 2B, less than 3 centimeters, so non-bulky stage 2B, it's still reasonable to do radiation. And in Europe, it's for just stage 2A that it's the preferred modality. And as you mentioned, based on that meta-analysis for stage 2B, they prefer chemotherapy. I think, just to give some historical context, with stage 2 seminoma, we used to treat these super extensive fields that went above the diaphragm, including the full mediastinum getting radiated. And obviously that led to a significant increase in toxicity. So just over a couple of decades, different groups, predominantly MD Anderson, Mayo Clinic, Princess Margaret Hospital, they tried to look at reducing the field size, maybe omitting that supradiaphragmatic field and removing these other elective nodal areas. They found that there was a slight decrease in progression-free survival when you did that. So there may have been a benefit to treating these fields, but that was abrogated in the CT staged era, which gets back to my older point. So when we have CT staging, we might be able to get away from treating these bigger fields. Overall, that's led to a compromise that now the standard of care for stage 2 seminoma with radiation is we do treat that dogleg field that I mentioned. So it is the PA strip and then the ipsilateral hemipelvis. We treat it to 20 gray, which is the same dose that I mentioned before. But then we boost the node that's visible. So if it's a stage 2A, which is going to be 2 centimeters or less, it's a 10 gray boost. So that's 5 doses of radiation. Or if it's a 2B, usually these are 3 centimeters or less. On rare occasion, you have a bulky stage 2B, maybe that decline chemotherapy or something. We're treating that anyway. You boost the lymph node in a 2B situation to 16 gray, which would be 8 more fractions of radiation. The field border is still similar to what we described before. So T11, T12 interspace is the superior border and the top of the acetabulum for that pelvis. And it's highly effective. There are recurrences, but it is a highly effective treatment.
That's so helpful. And it's always nice, and we tried this really hard on our show too, to make sure that we're appropriately interpreting the data for our clinical use, and trying to understand how to critically appraise literature is important. So thank you for giving the perspective of the radiation oncologist in the room for our listeners as well. You sort of alluded to this moments ago, and as you pointed out, our patient population in general with testicular cancer is a younger patient population. And therefore, there need to be conversations had along the way about organ function and fertility. And we know that our urology colleagues are often the ones that initiate these conversations because often they're seeing these patients initially for their orchiectomy. But we're curious for you, what are some of the impacts that you counsel patients about with regards to radiotherapy on spermatogenesis and even things like erectile dysfunction? Do you guys have a conversation about that as well?
Yeah, again, great questions. And so I'll take those in sequence. So with fertility, the spermatogonia, which are basically like the parent cell in the development of sperm, are extremely radiosensitive. So doses of like 0.15 gray lead to temporary impairment, and 4 gray, which is much lower than the doses I was mentioning, leads to permanent stability. So that's kind of a significant thing. The way that we try to limit that when we're doing radiation is we use something called a clam cell. The official term is the lead testicle sealed. It's like a lead device that you put around the remaining testicle. It will significantly reduce the dose of radiation that the remaining testicle receives. It's not perfect. I think the mean dose that it gets from the periodic field with the shielding is around like 0.5 to 0.6 gray, but that is below that threshold of causing like a permanent impairment. And so what I counsel patients is to use contraceptive. That first, it is always a good idea to try to bank sperm because patients may be needing chemotherapy or something like that, but that's something that may need to be discussed up front even. That said, after radiation, I tell my patients that they should actually use contraception very religiously for 6 to 12 months because the sperm actually may have survived but have incurred mutations. And so there's been some earlier work that certainly if someone does, impregnate someone and they've had radiation, the fetus could have some genetic abnormalities, right? So it is important for someone to use contraception for up to a year after radiation, but we don't expect sterility as a consequence, at least for these types of treatments. In terms of testosterone production, so like the other cell within the testicle that's responsible for this is the Leydig cell. Those are thought to be actually radio resistant. And we know this from other malignancies that we treat in the pelvis. I treat a lot of prostate cancer, and in that setting, there are actually higher dose of radiation going to the pelvic lymph nodes, for example. And in general, that's not leading to significant testosterone production issues. So I don't think that's an issue for these patients. And for that reason, we don't really expect the patient to have any significant hypogonadism incurred from this part of the treatment.
Cool. And then as far as effects on like the nerve network around the prostate that leads to normal erectile function, do you ever see issues with that, or are there any other long-term effects to look out for? I feel like every few months in New England Journal of Medicine, the clinical case or clinical image is like radiation recall or some bizarre thing like that. Are there other sort of long-term effects to be thinking about in the pelvis or beyond?
Yeah, that's because the New England Journal of Medicine has a strong anti-radiation bias. Well, so that's a good point about the nerve networks around the prostate, or the neurovascular structures around the prostate, and I could speak a lot to that only because I treat a ton of prostate cancer, but this comes up a lot more frequently. We tend to think that it's ED after radiation is like a vascular mediated process, and the vessels are relatively radio resistant. They're not going to be incurring damage at the doses that we use for seminoma, which are far lower than the doses for prostate cancer. And also, for like a stage 1 seminoma, we're treating just that PA field. So there's essentially very, very little dose to this area around the prostate. And even if you're doing the dog leg field and kind of covering the pelvic lymph nodes, you're still very far from that, neurovascular bundles around the prostate. So there shouldn't really be any ED from this type of treatment. However, as you're alluding to, there can be some substantial long-term morbidity that is worth being worried about. And I think the two major things of this is what has driven radiation dose de-escalation. The first is like a secondary malignancy, a radiation malignancy, and then the second would be cardiovascular toxicity. So at least in the radiation oncology literature, we have strict criteria for what's a secondary malignancy. So it's going to be the tumor is in the irradiated field. It's a different histology than the primary tumor, so it's not a recurrence. It's a tumor-free interval typically of 5 to 15 years, and there's no evidence of that cancer at the time of the initial treatment. And this is just because you will see people say, some got prostate cancer radiation, their second malignancy to lung cancer. And, that's clearly not related to the prostate radiation that they have. So that's why we have this strict criteria. That even with that strict criteria, there clearly is an elevated risk of secondary malignancy in this patient population. The detailed studies that had all that information to look at this estimate that risk around maybe on the lower end, 2%, on the higher end, 5 to 7% risk of a secondary malignancy, which is quite high, right? Now, could it be that patients that are prone to develop, a seminoma have some DNA repair or something that makes them more prone to this, and that could have happened anyway? I mean, we don't know, but it's worth de-escalating the treatment when we can, especially in this patient population. So I'd say that's like the first major long-term side effect we would be concerned about. The second is cardiovascular toxicity. And I'm sure you're all aware there was a major paper many years ago, like 20 years ago, I guess, it's 2005, that reported on cardiovascular toxicity after treatment for seminoma. And they looked at relative risk after chemotherapy, radiotherapy, and combination therapy. And these relative risks were quite high. I think after radiation, it was 2.4 relative risk, after chemo, 2.6. So that's significant. Now, this was published in 2005. This is based on patients treated in 1982 to 1992. I don't even know if you guys were born in 1992, but this is a long time ago. Things have changed, right? So mainly, we don't treat the mediastinum anymore. However, there's still some cardiovascular toxicity that's probably related to incidental radiation of the pancreas and maybe the renal hilum that's leading to possibly diabetes, possibly hypertension. And, when we're treating the PA field, that could occur. So, I think that is a real risk, and we just need to counsel these patients on preventive health measures as best as we can, monitoring for atherosclerosis, lipid profiles, diabetes, etc. But that's the conventional thought now, is the cardiovascular toxicity that someone might experience from seminoma treatment is really from that source. So some kind of renal irradiation or pancreatic radiation.
Such important things to look out for. And, I think that this is good for us to know, as well as we continue to see our patients long-term in our clinics for surveillance purposes and monitoring after their treatments are over. I feel like every single time we have the ears of a radiation oncologist on our show, we ask a question about proton therapy. So you weren't going to get away without us doing the same to you, because the reality is, this comes up, I think, in every other conversation where we talk about the role of radiation with our patients. Somebody inevitably brings up, well, what about proton therapy? I saw an ad for that, or I saw a billboard, and we're always like, I don't really know what that is. And so I'm going to ask you, Amar, what is the role of proton therapy, if any, in testicular cancer? And is there any, more recent data or literature to support its use?
Yeah, no, that is a great question. And I'll give the caveat that we don't have protons at the institution that I work at. So, you could argue that I have my own bias. However, I try to be evidence-based. And so I think it may be helpful to your audience to briefly discuss, why do people even talk about protons? And so, most radiotherapy is photon, and that's the X-ray based treatments. So the way an X-ray works is it delivers most of its dose at pre-specified depth. So you prescribe, I want most of my dose to be at this depth in tissue, and it does a good job of delivering that dose, but it has an exit dose after that. It doesn't immediately go to zero. Proton beams have a physical property called the Bragg peak, wherein it does deliver the dose at depth, and then there's very little exit dose. And so obviously that sounds great, and that underlies the premise of why proton beam therapy may lead to reduced toxicity. It doesn't have that exit dose after it hits where you want it to hit. So less dose to the organs at risk, therefore less toxicity. And that's been shown in a lot of, the term we use for it is an in silico study, meaning like a planning study. So patients may have been treated with X-rays, but you go back and you see what would have happened if you treated them with protons. And the doses look better. There's less dose to the kidney. There's less dose to the bowel. That's not arguable. The physics suggests that the doses are better distributed. And there have even been modeling studies where people say, okay, predicted on that less dose, is there going to be less toxicity or even less secondary cancers, which is the first major morbidity we talked about. Now, it's important to note that there is a difference between an in silico planning study and an in vivo clinical trial. And part of that could be that there are some uncertainties that the dose that you're looking at on the computer screen is the dose that's actually delivered in the patient. Particularly with protons, which are complex particles, we don't fully understand that the dose we think we're delivering is what we're actually delivering. And the reason I say that is very recently, there was a large randomized trial in prostate cancer, photon versus proton radiation. This has been a topic for years. Protons were thought to outperform photons. The trial showed no difference in toxicity, ultimately. And so I think one of the takeaways there was that, what you see on the computer screen either doesn't actually translate to what's delivered in the patient for a variety of reasons, or our models on toxicity prediction may not be accurate. So back to seminoma, it's a rare disease. We're never going to have a randomized trial. I don't expect to have a randomized trial. I think we're just going to have to extrapolate. And Even though I don't have protons, I would say, yes, it's a young patient population. If we can try to minimize the dose of these structures, it kind of makes sense. If it's available to use that. It's not always available. I wouldn't counsel a patient to interrupt their life to travel somewhere and incur a lot of financial hardship just to get proton studies. We don't have proof that it's better. But that's why you hear about it. And yes, there's some rationale to support.
Thank you for going over that. I'm really glad that you brought up the difference between in silico and in vivo. In silico, these are sort of necessarily models based on our current understanding, and the standard model in quantum physics may still be the most successful theory in physics history, but we know it's strong. we know there's something off about it. So it's very interesting to point out that there's these differences when you actually look at what happens to a patient. Anyway, speaking of cutting edge stuff, what are the sort of the emerging research, clinical trials stuff going on that's shaping the landscape of the future in radiotherapy for testicular cancer?
Yeah, sure. That's a great question as well. So I think the major topic of excitement is the role of combination therapy for stage 2 seminoma. I imagine that's exciting in the medical oncology world as well. So there's some recently published studies. One was a small trial out of the Royal Marsden Hospital that looked at a single cycle of carboplatin, followed by 30 gray of a reduced field for stage 2 seminoma. And they had a progression-free survival of 100% at 55 months, a median 55 months. And then probably the most prominent was the SAC 0110 trial, SAKK, so it's a Swiss group. They evaluated the use of carboplatin, that was one cycle again, AUC7, followed by involved nodal radiotherapy, which is like a substantial reduction in radiation field size. So instead of treating this PA strip, they just took the positive node, expanded it by 2 to 3 centimeters, and then just treated that. 30 gray for 2A and 36 gray for 2B. And they had a median follow-up of 4.5 years. Their 3-year progression-free survival was like 93.7%, which is really good, but it did miss their mark of 95%. So technically, it was not a positive non-inferiority study. However, like in the fine print, that may have been driven by these stage 2B seminoma patients. That going right back to what you were asking at the beginning, maybe this is more of an approach for stage 2A seminoma. And they had really good outcomes on that trial. Current open trials are kind of just building on that. So there's the next trial from that group is the SAC 0118 trial. So they're looking at further reduced dose nodal radiation. So it's like 24 gray for 2A and 30 gray for 2B, along with carboplatin for 2A. And then for stage 2B, they're giving cisplatin etoposide. And that's because that's the group that had more recurrences in their first trial. And then the only other kind of active, larger trial is called the Eden trial out of France. And so that's looking at patients with stage 2B seminoma that get EP, and then they get a PET. If the PET is negative, they're actually randomized to get nodal radiotherapy versus carboplatin. And then the people who have a positive PET just get more chemotherapy as they likely. And that study may be interesting because it's looking at the role of these microRNAs. I'm sure you've heard that in the workup of germ cell tumors, but this would be looking at how useful it might be in a surveillance setting, and if it could identify the people that need the chemo versus not, et cetera. So those are going to be kind of important trials. And then I think, although this isn't what you asked, it's probably worth putting a note out there that there have been surgical trials for stage 2 seminoma as well. So there are two, the SEMS trial and the PRIME test trial, and I would fully defer the discussion of the nuances of those trials to a urologist. But it's important to note that the 2-year progression-free survival in those trials was like 81% in the SEMS study. And in the PRIME test study was like 30% recurrence rate at a median follow-up of 32 months. And those are higher recurrence rates than what we're talking about with either chemotherapy or radiation. Now, of course, devil's advocate, those are surgical patients, so they shouldn't have the long-term morbidity that we may be worried about with radiation and chemotherapy, and that's the whole premise, but it also was not as effective.
That's great to know. And for a rare disease, I'm glad that there is still so much interest in this. And I think truly, I can't underscore enough for our listeners that we have to remember that, our patients are young, right? As Amar is pointing out, there are a lot of long-term potential complications, and these patients may have 50, 60 years ahead of them that they have to live with these potential complications. So whatever we can do to help minimize some of those risks now and improve our methodologies now are going to benefit our patients in the long run. Amar, any final thoughts that you have? I mean, I thought this was a fantastic discussion. Truly, I understand how our radiation oncologists fit into this picture so much better than I did before we started this conversation 30 minutes ago. But I want to turn it over to you and just see any final thoughts that you have.
No, I mean, I thank you again for the invitation. I think it's very important to have these kind of multidisciplinary discussions. We can all benefit from learning from one another because likely, what we read about chemotoxicity is different than what you guys are seeing in your clinic and vice versa. It's always a pleasure to do these multidisciplinary discussions.
Well, that's wonderful. All right, guys. Well, I think that wraps up another fantastic episode of the Fellow on Call. Until next time, we'll see you all later.
Peace.